your more enthusiasm and more knowledge and more clinical outputs, because we have eminent speakers today. So not to waste much time, we are handing over the platform to Professor Mihi Sarkar, our this all webinar. So Mihi sir, the platform is yours.
Now, Sumantro, you can continue because, and I welcome on behalf of Bengal Pediatrics, I welcome you all in the day second of this online symposium on the steroid sensitive nephrotic syndrome according to this ISPN guideline. So yesterday we had a very engaging and interactive session, and there is a flood of questions in the chat box, and the interaction goes up to 10:30. Sumantro, or beyond that, I left at 10:20. At that time, the full discussion was going on. So again, today also we are expecting the similar interaction from all of you. Already, I think within few minutes, all of them will join in the participant. And today we have also the galaxy of experts, Dr. Shubhankar, Dr. Jitendra Meena, and our own Susmita Madam. And we have chairpersons, senior pediatricians and the nephrologist, Dr. Amitabh Pahari sir, and our president-elect of West Bengal Academy of Pediatrics, Professor Swapan Kumar Roy. So I will hand over to Professor Swapan Kumar Roy, who is now the professor of MGM Medical College, Kishanganj, ex-professor of the Institute of Childhood, and the present president-elect of West Bengal Academy of Pediatrics, and also member of AC VIP of Central IIT. Over to you, Swapan sir, and Amitabh Pahari sir.
Before Professor Roy actually takes over, let me say a few words about Professor Swapan Kumar Roy. Apart from his current designation and affiliation, I remember my early association with him, even before BSPN actually formed officially. Whenever he was organizing any conference, I used to be a kind of definitive speaker talking on various aspects of pediatric nephrology. So I should, as BSPN president, I should give him due credit for promoting pediatric nephrology at a very early stage, even when he was just organizing secretary and president of Howrah branch of Indian Academy of Pediatrics. Many thanks for doing that, Professor Rai. Now, may I invite you to kindly introduce our speakers for today, Dr. Sarkar, Dr. Banerjee, Dr. Jitendra Meena, and start the proceedings. Professor Roy, it's all yours.
Thank you, Paharida. In fact, I call him Paharida. Actually, I respect him from core of my heart because he has sensitized us about the pediatric nephrology. And whenever there was any program in Howrah, he has truly said that I used to invite him. So it's my pleasure to be associated with him for a long period. And now we'll move on to our session. So it will be Dr. Shubhankar Sarkar. He is the assistant professor of All India Institute of Medical Science, Kollani. And Dr. Shubhankar has done his MD Pediatrics from AIIMS, New Delhi.
Kindly say the slide, please.
He is also the fellow in pediatric nephrology, ISPN AIIMS, New Delhi, and NUH, Singapore. So over to you, Sumantro.
Okay, thank you, sir. I think we start this session. Thank you so much for kind introduction. And thank you so much, the West Bengal Academy of Pediatrics, for arranging such a focus and such a needed program for our current situation. So I'll focus mainly on the edema control and nephrotic syndrome. So we are following the index case, that is Ankit, 4-year boy, weight about 20 kg. His nephrotic syndrome was diagnosed in January 2023. Initial onset was not adequately treated. We can see 6 weeks daily steroid followed by no data or the steroid is not treated properly. And subsequently, he had a 3 relapse in 2023. Although treated adequately, but in last 6 months, year of 2024, he got around 3 relapse. We can see the high dose steroid, alternative steroid, he got relapse 25, 20 mg and 30 mg alternative steroid. And currently in the 6th relapse in May 24, he developed massive vena sarca. We can see the picture, the face picture, bit of steroid toxicity plus edema. and the abdomen, the legs, the whole body, it's a huge swelling. So he was admitted in the local hospital, and they treated with available resource, like they give diuretics with Lasix and ceftriaxone. And unfortunately, he developed some generalized tonic-clonic seizure. The cause of seizure could be multiple, like infection. That's why they started with the ceftriaxone. It could be electrolyte imbalance due to the nephrotic or due to the Lasix, or it could be other like hypovolemia, sepsis. So multiple reasons actually. So I'm not going to discuss detail on complication of nephrotic syndrome. That is the next topic will be discussed by Dr. Meena. So I'll focus on controlling edema in a better way. So edema control, how to do actually, is the only one option, like diuretics, furosemide, that is commonly used. Swelling is there, so we can give the diuretics to reduce the edema. So this is the only option, or there is other multiple option like using of albumin, and or both combination, diuretics plus albumin. So if it is used diuretics, what will be the route? Like, can I give orally? Can I give IV bolus? Or need any infusion? So all are there, but how to give and when to give, and what will be the consequence? What are the circumstances we should use such medicines? If I use albumin, what percentage? It is 25%, 20%, or 5%. So that's the situation will decide what percentage of albumin we can give. Or anything else to add on the treatment. Like water restriction. So nephrotic syndrome can present edema because we know that one of the diagnostic criteria of nephrotic syndrome is the swelling. So any child got the diagnosis of nephrotic syndrome could have some amount of edema. And even they relapse anytime in subsequently, they could have some extent of edema. But most of the edema is like mild, and they doesn't need so much of treatment, and they gets better within its own actually after the controlling the underlying disease. So we can classify the edema according to the weight gain. Mild edema is like weight gain of less than 7%, and that is very benign. If it is moderate edema, that is weight gain of 8 to 15%. If it is severe edema, that is weight gain of more than 15%. So how can I manage a mild edema? So I already says that mild edema is common. Mild edema management is very not so difficult. So we just manage conservatively. Here doesn't need so much of diuretics, doesn't need to restrict the fluid. Just we can use the steroid at a adequate timing, proper dosing, because steroid has got induced the Brix diuresis. And if the steroid able to control the underlying disease, so whole things will be changed and normalize within the few days. So mild edema, common, but it's easy to treat. But the problem with that moderate to severe edema, because moderate to severe edema can have a multiple complication, multiple physiological disturbance. Like half of the patient during relapse could have a volume contracted state. And this volume contracted state is most common in moderate to severe edema. So in that situation, if we give blindly such as Lasix, can have a complication, like child worsening the shock with the hypovolemic shock, can develop AKI, can develop electrolyte imbalance, and other complication of the diuretics and the hypovolemia related situation. So how to assess the intravascular volume status? So first we can ask few questions and can assess the patient about the hypovolemic status. Suppose if you ask the patient for the fluid intake, how much fluid was taking? Many time nephrotic syndrome patient could have an infection, they could have some lethargy, kind of thing, URI, infection. So the intake can be low, like child is not taking adequately fluid or taking very less or different type of fluid. And many times they could have a GI infection like diarrhea and vomiting. So fluid loss, less fluid intake could be one of the reason. Along with that, intravascular hypovolemia due to the hypoalbuminemia and nephrotic relapse. So we need to search for the cause why the child is having hypovolemia. The child with hypovolemia could have a abdominal pain because due to hypovolemia, there is a less blood flow to the gut vessels and is due to the intestinal angina kind of things like intestinal gut ischemia. Gut ischemia leads to the pain. They could have a other cause of pain like gastritis, pancreatitis, surgical cause, or other cause. But one of the reason, if you see peritonitis also, UTI also, but if it is not there, the child is on relapse, on complaining of pain, we need to think about the hypoalbuminemia and due to the hypovolemia and leads to the gut ischemia. They could have a picture like nausea, vomiting, and other classical picture of hypovolemia like lethargy, dizziness, tachycardia, pallor, cold periphery, delayed capillary refill time, low blood pressure, postural hypertension, and ultimately the hypovolemic shock. So history and examination is very important to pick up early and treat accordingly so that we get a good result. There is some biomarker. Sometimes we fail to detect by clinically because needs expertise and needs a lot of concentration to pick up that symptoms and sign. So what we can do after doing proper history and examination, we can do for some biomarkers like FeNA, that is fractional excretion of sodium. It's very simple. I think we are very familiar with the formula urine sodium into plasma creatinine divided by urine creatinine into plasma sodium. So we are familiar with this formula with pre-renal versus renal AKI. So it is less than 1% is most commonly say is a pre-renal situation, but in nephrotic syndrome, many a time it could be less than 1%. But if it is less than 0.5%, that's it's reliably say that intravascular volume is low or child is in hypovolemic state. Other index like potassium index that is calculated by formula of urine potassium divided by urine potassium plus urine sodium. If it is more than 0.6, that is indicating hyperaldosterone activity in the distal tubule. That is absorbing sodium from the distal tubule and excreting potassium. So these two are the more reliable and sometimes it's a subjective parameter to assess the intravascular volume status in a very quick way. Other soft sign of intravascular volume status like rise of hematocrit. So if it is more 8 to 10% of rise of hematocrit can say there is a intravascular hypotension. The same situation happen in the dengue shock syndrome or dengue hypovolemic situation. Other like high blood urea to creatinine ratio. So we all familiar with that things with pre-renal versus renal AKI. So these are the soft marker to say that child is having intravascular hypovolemia. And another point is the hyponatremia. Very interesting things is that in nephrotic syndrome, there is a huge swelling, but child could have a hyponatremia. May or may not be symptoms is there. Many a time they are not symptomatic. Sodium of 120, 122, they don't have his symptoms because it's a dilutional hyponatremia. The child total body sodium could be more than high or just near normal or high. Many times it's a high actually. So hyponatremia could be there actually. So if you correct the physiology, if you correct the hypoalbumic state, if you correct the proper physiological balance, sodium automatically corrected. So many a time doesn't need any sodium infusion giving extra salt. So it's correct automatically. Even we restrict the sodium in that situation also if the hyponatremia is there and we need to give the albumin and other things to correct that hyponatremia. Other way of assessing the intravascular status like in doing regularly in PICU, ultrasound guided inferior vena cava collapsibility test. And more researchable kind of things is like bioelectrical impedance analysis to assess the total body water. So for us, very simple that we can assess the intravascular volume status by doing history examination and by doing some few tests like FeNA, potassium index, and hematocrit, sodium. These are there to support the diagnosis. So once you get the diagnosis of hypovolemia with mild to moderate to severe edema, you need to hold the diuretics because hypovolemia diuretics very dangerous. It's like worsening the shock, hypovolemia to the shock. You also hold to the other antihypertensive drug because moderate to severe hypovolemia, edema is most commonly happen with the difficult to nephrotic syndrome like SDNS or SRNS. Many a time they are on some antihypertensive drug, specifically enalapril and diuretics also. So we need to stop that. Otherwise, it's going to cause further worsening of the hypovolemia, can cause AKI and other such big complication. In that situation, we need to correct the hypovolemia by giving albumin. So they most of the time would have a low albumin level. So better we give the albumin. So 20% albumin is the choice here, not the 5%. So 20% we used to give over 4 to 6 hours. At the end of the infusion, we give Lasix 1 to 2 mg per kg. And definitely to monitor that situation, because if you give the albumin, it suddenly increase the intravascular volume. It's shifting the fluid from the extravascular space to the intravascular space. And if the kidney is not able to handle that extra volume, there is a chance of intravascular hypertension and may lead to pulmonary edema and heart failure also. Very important to monitoring this situation, giving albumin also. Better to admit the child, and while giving, you need to monitoring the vital parameter intake output regularly. If the child presented with the hypotension or hypovolemic shock, many emergency doesn't have 5% albumin. In that situation, you can use normal saline to correct the physiology, to immediate correction. Otherwise, child going to be irreversible situation, irreversible damage to the other organ. And if you have the 5% albumin, you can give as a bolus to correct the hypovolemic status. So you can manage hypovolemic nephrotic syndrome in that way. If the child is having edema without hypovolemia, so then you can give diuretics to control the edema, and definitely you need to restrict the fluid. So usually say that around 2/3 of the fluid restriction or half of the maintenance we can restrict, but definitely you have to monitor. If you restrict so much, they can enter into the hypovolemic status. So fluid restriction will help here. Diuretics will help here. Also the sodium restriction. Sodium restriction will help here. So it says that about less than 2 milligram per kg per day will help to control the edema. And you can consider to add spironolactone and other diuretics. Spironolactone has got anti-aldosterone action and also correct the hypokalemia that is caused by the loop diuretics. If the child is having AKI without hypovolemia, so AKI without hypovolemia, just management like maintaining the physiology, general care of AKI, like we give to the maintain the intake out balance, electrolyte balance, calorie protein maintenance, avoid nephrotoxic agent, modify your medication dosage like antibiotic, inotropium, etc. We can manage the things in a way. So sometimes even after doing all these things, child may land up with the diuretic resistance. So fail to achieve the desired reduction of the weight despite maximum dose of diuretics. So this situation happens mainly the heart failure, severe nephrotic syndrome like SDNS and SRNS kind of situation, and cirrhosis of liver. So the cause is like compliance is poor, not poor salt restriction, medication and fluid restriction, not following the instruction. There is a gut edema. You know, the gut edema can cause decreased absorption of the medicines. Like if you give the diuretics orally, that not going to absorb, not work for you. So you have to change the route from oral to IV. Also, the albumin and intravascular hypovolemia is there. The albumin infusion will help here actually. Accumulation of the other endogenous products. So you need to take care of the infection and catabolic state. If there is a reduced GFR, AKI is there, and compensating increase of sodium absorption, we need to take care also to maintain the physiology to get better result. The management mainly improve the compliance with the salt and fluid and medication, restrict fluid intake, albumin and furosemide infusion if needed, and continuous furosemide infusion needed many times. So what are the diuretics? I'm giving the brief table for commonly used diuretics. So furosemide is most commonly used. Oral dose is like 1 to 6 mg per kg per day. If you're using IV, then 1 to 4 mg per kg. If you want to give infusion, 0.1 to 1 mg per kg per hour. And other diuretics like torsemide, hydrochlorothiazide, metolazone, these are the distal blocker that can be combined with the furosemide to get a sequential block to get the better result in case of diuretic resistant or difficult to treat edema. Spironolactone, amiloride, I already mentioned, these are the anti-aldosterone potassium sparing diuretics that can be helped to control anti-aldosterone hyperactivity and hypokalemia induced by loop diuretics. Acetozolamide and mannitol, we very rarely or never use in controlling edema in nephrotic syndrome. So the question sometimes arises that furosemide versus albumin plus furosemide. So if you want to choose to give albumin in patient, you decide to give albumin, so better we give the albumin and furosemide combination. So I have mentioned that the study shows that if you give the combination, it will give a good result. So albumin infusion followed by furosemide at the end of the infusion will get the better result. So I think now trying to summarize my presentation to how to control severe, moderate to severe edema in nephrotic syndrome. So first you assess the hypovolemia. If it is there, child is in shock or not. If the child is in shock, you just try to give normal saline bolus. If the albumin is available, 5% albumin, bolus will restore the correct the shock, underlying shock, and subsequent management according to the situation I have mentioned. If there is no shock, but child is on hypovolemia, so here the albumin infusion will help. So dose is like 0.5 to 1 gram per kg, followed by furosemide 0.5 to 1 mg per kg at the end of infusion. If the child doesn't have hypovolemia, so oral furosemide 2 to 4 mg per kg, better to give better higher dose per day, and consider adding spironolactone to get better result. If not improved, you can add metalazone to 0.1 to 0.3 mg per kg per day, or change to furosemide higher dose like 3 to 5 mg per kg per day. Even still no response, then you can consider to give IV furosemide at the dose of 2 to 4 mg per kg per day, and albumin infusion at the 0.5 to 1 mg, 1 gram per kg per day. If all is failed, refractory edema, in that situation, you can consider to give furosemide infusion 0.1 to 1 mg per kg per hour with albumin infusion, or albumin plus furosemide infusion. Sometimes few data is available for tolvaptan 0.5 to 1 mg per kg per day. And ultimately, if there is very refractory steroid-resistant nephrotic syndrome, not able to control the underlying disease, then you have to decide about the dialysis to ultrafiltration and removing the extra fluid from the body. So take home message from my presentation. Edema is common in nephrotic syndrome and sometimes very difficult to manage. Assessment of the hypovolemia is paramount importance for management of edema in nephrotic syndrome. And after that, you can choose the best modality like diuretics plus albumin, or adding other diuretics, or giving albumin. So these are modality only you can choose if you have a proper assessment, and then you will get a good result. Okay, thank you so much. I think I have finished within the time. Can I have some questions or anything, sir?
Yes. Thank you, Shubhankar, for finishing in time. There are few questions if you can answer. It's Dr. Narayan Shantuka. He has asked, sir, in a volume contracted state, there should be hypernatremia.
No, actually, in nephrotic, the total body sodium will be high, but many a time due to the dilution, very rarely you can get hypernatremia. That could be different reason. So most common situation will be the hyponatremia, and that will be corrected by restricting fluid, restricting sodium. And if you have a severe hyponatremia, then choose to give albumin. Albumin can correct shifting the fluid from the extravascular to intravascular, and then kidney will handle the free water from the body, and will get corrected by automatically actually. So hyponatremia in nephrotic relapse, very rare situation. It's very rare actually, sir, unless until there is a diarrhea and other etiology.
It's Sneha. She has asked, in the flowchart, if hypovolemia but not shock, we can we give furosemide? Hypovolemia but not in shock, can we give furosemide?
So I have mentioned that if you have a hypovolemia and not in shock, diuretics only is not good actually. If you give diuretics, hypovolemia can enter into the situation of shock. So better use albumin plus diuretics. So it will shift the fluid and correct the hypovolemia also.
The other question by Dr. Mukul. Is there any criteria for refractory edema?
So actually, there is some criteria that if you give the diuretics and if you are expecting some weight loss, like there is a few criteria, I don't remember that actually. There is some criteria of weight loss. So there is if you targeting some weight loss is not achieved by doing diuretics, then you can say it's a refractory loop diuretic refractory edema.
So again, the other question from Dr. Narayan Shantuka. In the communication of my first question, in the connection, continuation of my first question, but in volume contracted state, where the cause of edema is hypoalbuminemia, what is the mechanism of hyponatremia? And there is free fluid state due to decreased oncotic pressure, which should cause hypernatremia. Am I wrong anywhere, sir?
Okay, so actually, in nephrotic edema, usually what happened? So fluid sodium, there is a two theory. I mean, you know that actually, that once the most important theory that the albumin is releasing from the body. So there is a hypovolemia. Due to hypovolemia, there is a disturbance of Starling force leads to shifting of the fluid from intravascular to extravascular. What happened? There is other mechanism also like activated, like RAS activation syndrome. I mean, renin aldosterone axis, and also the vasopressin. So vasopressin will absorb the free water from the body, not allowed to excrete the free water from the body. And child is also continuously taking the fluid. So this fluid is going to add to the intravascular space. So that diluting the plasma sodium to less leads to the hyponatremia.
So Dr. Paharida wants to tell something.
So, Uncle, many thanks for taking us through edema management and control in nephrotism. That was really great. But what happened to Ankit?
Sir, Ankit is going to be managed by Dr. Meena.
No. What went wrong in controlling his edema? That's your.
Sir, I have mentioned, sir, that the details history need to check.
Went wrong.
Okay, so not checking the hypovolemia, giving Lasix blindly, say, I mean, kind of, Lasix is always used judiciously. You have to assess the intravascular volume status. And if indicated, we can give, not indicated, we can use with albumin, or we can avoid the things for a few hours or few days. So it could be due to injudicious use of diuretics leads to electrolyte imbalance and lead to hyponatremic seizure, or it could be like worsening of the shock lead to ischemia of hypovolemia leads to complications could be there, sir, or could be infection because they have started the ceftriaxone also. So it could be the multiple reason, but most commonly I would suggest not to use the diuretics blindly.
Right.
I think, very high, rightly mentioned by Dr. Sarkar. I think when Sumantra possibly, conceived this scenario, he wanted us to aware of cerebral thrombus when actually, give particularly diuretics in a child who might be in hypovolemic state and hypercoagulable state. So chances of venous thromboembolism giving rise to seizure is not very, very uncommon. So we should all be very careful about it. Many thanks, Dr. Sarkar. Now I'll ask Professor Roy to kindly introduce Dr. Jitendra Meena so that we have to go for the next step. Dr. Sarkar.
So welcome, Dr. Jitendra Meena. Dr. Jitendra Meena is the Assistant Professor of Department of Pediatrics, AIIMS, New Delhi. And he is also the Joint Secretary of the ISPN 2024 and 25. He has got 70 publications in international journal and 15 book chapters. And his area of interest is chronic kidney disease, kidney transplantation, urinary tract infection, and evidence-based medicines. So we're eager to listen to you, sir. So please continue.
Thank you, sir, for that kind introduction. Am I audible?
Yeah, perfect.
So at outset, I would like to thank the organizing committee of this academic activity. I'm sure that it would benefit the postgraduate and other practicing pediatricians. So the topic which was given to me is complications of nephrotic syndrome. So I would be, overall covering the complications of nephrotic syndrome in the next 20 to 25 minutes. And I been very simple in drafting this presentation. So taking from Dr. Sarkar, the patient Ankit, 5-year-old, who had frequently relapsing nephrotic course, which we have seen in the last presentation. So this time when he presented in relapse, there was, apart from edema, there were complaints of abdominal pain and seizures as well. So taking from there onwards, so abdominal pain in nephrotic syndrome, especially in patients who presents and relapse, is a common clinical symptoms which parents usually complain. So there can be various underlying etiology for abdominal pain in these patients, beginning from the pretty innocuous of steroid-induced gastritis. So it can be hypovolemia, peritonitis, abdominal wall cellulitis. In fact, they may have viral gastroenteritis, renal vein thrombosis, and they may be very severe underlying etiology like pancreatitis, and maybe people have rarely also reported surgical causes like intussusception and appendicitis. So hypovolemia has already been covered by Dr. Subhankar. So most of the patients who present in relapse or frequently relapsing, they are already on corticosteroid therapy. So gastritis can be a common symptoms, and I'm sure that based on history one can rule out the gastritis. Patient with peritonitis, would are most of the time sick looking. They might have other associated complaint beyond abdomen, like they may have fever, they may have loose stool, nausea, vomiting, and they might be difficulty in walking, because while they walk there is a irritation of peritoneum, and that might aggravate their pain. Cellulitis can be examined on physical examination. Renal vein thrombosis obviously is a diagnosis which is not that common, but if patients have decreased urine output with the gross hematuria, in setting of relapse, one may consider renal vein thrombosis. Pancreatitis is obviously the abdominal pain is referred back to backside, then one may suspect pancreatitis. So coming to the one of the most common cause of abdominal pain in patients with nephrotic relapse is infections. So the patients are at increased risk of infection, with contributed by multiple factors. One is that there is a loss of the proteins in urine. So overall, there is a reduced immunoglobulin levels in the serum, which contribute to increased risk of infection. People have reported that there is impaired T cell functions as well. There is a deficiency because of loss of protein, factor B and factor D, which are regulator of complementary pathway, and there is a overall reduced immunological response to bacteria. And many of these patients who are frequently relapsing or steroid dependent course are on immunosuppressive medications, which also contribute to increased risk of infection. Edema itself can, is a potential for growth of the bacteria, especially in subcutaneous space. If you have breach in the skin barrier, then they may lead to cellulitis or superficial skin infection. So as we can see, there are multiple factors which increase the risk of infection in these patients. Commonly encountered infections in patients with nephrotic syndromes are peritonitis, pneumonia, maybe sepsis, cellulitis. So coming to the bacterial peritonitis, presentation is chiefly, as I already described, is fever, abdominal pain. They may have loose stool, vomiting, nausea. And during our training, Professor Bagga used to say that a patient is having severe edema, pain, abdomen, and is having difficulty in walking, he's likely to have peritonitis. Organism which chiefly cause bacterial peritonitis in patients with nephrotic state are Streptococcus pneumoniae, E. coli, Streptococcus pyogenes. So Streptococcus pneumoniae is the most common organism, followed by E. coli. Then there may be rarely other gram-negative bacteria. Diagnosis is chiefly based on peritoneal fluid tap. So if you find more than 100 leukocyte WBCs, which of at least 50% should be neutrophils, one can make a presumptive diagnosis of peritonitis, and obviously one need to look at the gram stain as well as send cultures. The problem with cultures that we hardly see positive cultures, so one would most of the time rely on the ascitic fluid examination for making a diagnosis of spontaneous bacterial peritonitis. Therapy, chiefly, one would start with the empirical therapy of third generation cephalosporin, and most of the time 7 days are enough. So all these 7 days may need not to be intravenous. One can switch, from day 4 to day 5, patient is clinically improving. Then one can switch from intravenous to oral route. In fact, Dr. Sumanta's DM dissertation thesis was related to this, where he has demonstrated that one can switch, from intravenous to oral route. Other common infections are, pneumonia, where organisms are chiefly Staph aureus, Streptococcus pneumoniae, and diagnosis would be based on most of the time on X-ray. Blood culture one would need to send, but hardly, one get a growth. Empirical antibiotic therapy are chiefly amoxicillin, amoxiclav, because these are the organisms which are chiefly covered by these. And one would, consider giving 7 to 10 days of total duration of antibiotic therapy. Mycobacterium tuberculosis is still a problem, in our country, especially, lower socioeconomic status. So one would need to consider tuberculosis if there is a persistent cough and pneumonia is not improving. Cellulitis, again, chiefly related to uncontrolled prolonged edema, and their antibiotic of choice, because it's chiefly, the Staph aureus, which is the most common organism. So here antibiotic of choice is amoxiclav or cloxacillin with ceftriaxone for 7 to 10 days. Sepsis. So another infection which I would specifically want to mention here is varicella. Varicella, can be a life-threatening in patients with nephrotic relapse. So one would need to treat it aggressively with intravenous acyclovir. So I have seen patient, dying within 2-3 days with varicella infection in nephrotic state. So it can be, a very life-threatening infection. So as we see now that these patients are increased risk of infection. So is there any role of giving prophylactic antibiotics, or there is, low immunoglobulin level? So is there a role of IVIG? So overall evidence doesn't, suggest or support these interventions. There is some data that patients who receive rituximab, Ceftriaxone prophylaxis may reduce the infection, especially of PCP. Coming to the, one of the relevant topic when we encounter patient with nephrotic relapse and infection is stress dosing of the steroids. So because patients who receive prolonged corticosteroid therapy may have hypothalamic pituitary axis suppression, and evidence suggests that, as high as almost half of patients who receive more than 2 weeks of steroid therapy may have biochemical evidence of hypothalamic pituitary axis suppression. So ISPN guideline recommend that one would need to give stress dose steroid if patients have received high dose steroid that's more than 1 to 2 milligram per kg per day for almost more than 2 weeks within last 12 months. Then one would need to give stress dose steroids. So stress can be, very well severity. So what's considered, significant stress if patient is having a fever more than 38 centigrade, inadequate oral intake, lethargy, dehydration, there is a plant surgery, dental surgery, trauma, or large ones. Patients, with uncomplicated viral infection, post-immunization fever, one may need not to give a stress dose steroids. So, what's the dose? So, if there is septicemia, hypovolemic septic shock, critical illness, or there is a plant surgery, the dose recommended is intravenous hydrocot of 100 milligram per meter square first dose, followed by 25 milligram per meter square every 6 hourly. In less serious infection, we would give oral prednisolone of usually 0.5 milligram per kg per day. Or if there is decreased oral intake, one may consider switching to IV hydrocortisone. So this is important, especially in clinical practice. So coming to the next complication, so as we saw that Ankit beyond pain abdomen also had seizures. So patients with nephrotic syndrome may have multiple underlying etiology for seizures, which may vary from just hyponatremia, as Dr. Sarkar discussed last talk, that the patient have considerable hyponatremia. So that may be a cause. Then these patients are in increased risk of venous thrombosis. Rarely, especially patients who have complicated nephrotic syndrome on multiple suppressive drugs may have considerable hypertension, and they may have patient and have poor compliance or not taken medication. They may end up in hypertensive emergency, as we saw that there are increased risk of infection. So meningitis can be one of the possibility for seizures. So patients with nephrotic syndrome, especially when they are in relapse, are at increased risk of venous thrombosis. Arterial thrombosis is rare, but can be seen as well. So coming to the basic physiology, pathology days, this is, which was tried, which classically describe that increased risk of thrombosis in the vessels. So there are three things which contribute to formation of thrombus within the vascular lumina. One is there is hemodynamic stasis, or there is a stasis of blood or reduced blood flow. If you have hypercoagulability, so there is a mismatch between the procoagulant and anticoagulant factors, or there is an injury to endothelium. So these three factors increases risk of thrombosis. So in nephrotic state, we do see these two things: hypercoagulability and stasis or reduction in the blood flow. So this is chiefly seen in patients who are already hypovolemic, hypoalbumic, and upon that, if they have diarrhea or vomiting, and top of that, if you end up giving diuretics, so there is a relative intravascular hypovolemia, and there is a reduced blood flow. Hypercoagulability is chiefly because a lot of patients they are losing massive proteins. So overall, there is a more loss of antithrombin 3 and protein S, which are antithrombotic factors. So overall, there is an increased prothrombotic factor in the blood. Top on that, there is increased protein synthesis in the liver of prothrombotic factors like fibrinogen factor 5 or factor 8. So all these contribute to formation of the thrombosis within the vascular lumina. The most common site are cerebral sinus thrombosis. One can see renal vein thrombosis, other deep veins. Pulmonary thromboembolism is also encountered, but that's not a common scenario. So patients with venous thrombosis can manifest, as I told you, that begin with the cerebral symptoms. So they may have just patients with nephrotic relapse presenting with persistent headache, vomiting. So one may need to strongly suspect that there is a sinus vein thrombosis, and order a neuroimaging, especially MR venography or MRI. ICCT is not a good diagnostic modality for picking up the venous sinus thrombosis. So CT or MRI venography is a good modality. Then other symptoms which can, have so variable symptoms can be observed like seizures, irritability. Sometime you may have, the cranial nerve palsies as well. So overall prevalence, which has been reported in literature, is around 3 to 5% of the patient with nephrotic syndrome encounter venous thrombosis. So management, so one is, preventive strategy. So one should avoid, making patient dehydrated, especially in the nephrotic relapse setting. And patient should be ambulatory. And other factor which I forgot to mention in the previous slide, if there is a in situ central venous catheter, that also increases risk of thrombosis, because that leads to endothelial injury, and which was one of the factor which contributes to thrombus formation. So once we have established thrombus formation, therapy is either low molecular weight heparin, so we would start at 1 to 1.5 milligram per kg per dose, which would we would continue almost at 3 months therapy, and based on monitoring, if it's resolving, one can stop at 3 months. One may consider switching to warfarin with the target INR of 2 to 3, but in our experience, there is an increased risk of complications with warfarin, so we always prefer enoxaparin subcutaneous for 3 months therapy. Coming to Master Ankit, so this time Ankit had in next relapse complaints of abdominal pain, and there is a decreased urine output for last 2 days. So output monitoring after admission for next 24 hours showed 0.8 ml per kg per hour, and lab parameters showing urea of 90 milligram per deciliter, creatinine of 1.1, with hyponatremia and potassium being normal. So, as you know, Dr. Sarkar also mentioned that if you continue to hypovolemia continue to persist, these patients are at increased risk of acute kidney injury. So I'm sure most of you are aware that how do we define acute kidney injury and stages. So if there is rise in creatinine of 1.5 times or 0.3 milligram per deciliter, then it's called acute kidney injury. Or drop in urine output of less than 0.5 ml per kg per hour for 6 to 12 hours. So this kid has shown, that there was a decrease in urine output of 0.8 ml per kg per hour, but it's AKI based on the serum creatinine of 1.1 milligram per deciliter. So AKI is not that uncommon in patients, especially who are hospitalized with nephrotic relapse. So the reported overall incidence is 20 to 40%. So obviously it's maybe overestimated because mostly hospitalized patients do have some or other complication. So etiology which are common in nephrotic syndrome for AKI are that there is hypovolemia, top on, the intravascular hypoalbuminemia, if you have fluid loss in terms of vomiting, diarrhea, that aggravate hypovolemia, and hypovolemia persists beyond time point. This patient may develop acute tubular necrosis. Infections also aggravate. Then, drugs, nephrotoxic drugs like ACE inhibitor, diuretics, calcineurin inhibitors are another considerable cause of acute kidney injury. One may, rarely encounter that there is a bilateral renal vein thrombosis leading to acute kidney injury. So coming from the, this nephrotoxic drug, there is a concept of drug holidays. So people would say that during hypovolemic state, especially, there is a fluid loss in terms of volume, vomiting, diarrhea. One should withhold diuretics and enalapril therapy during that period to avoid the risk of, developing AKI. So once AKI is developed, there is nothing but one can do, one need to conservatively manage, discontinue the offending drugs. If there is hypovolemia, one generally need to, manage with intravenous albumin and diuretic therapy. Coming to the last complication, which I will be discussing, is many of these patients do have dyslipidemia. So dyslipidemia is a steroid-sensitive nephrotic syndrome is not a problem because it's a transient phenomena and it would resolve. But most of the parents, when they see the lipid, profile or cholesterol of, sometimes 300 or 400, they get worried. So one need to counsel them that it's a transient phenomena and it doesn't have any long-term consequences. And the patients who is steroid sensitive, but patients who are steroid resistance, persistent of lipidemia beyond, particular threshold may have long-term cardiovascular complications. So these are the target range one would need to, achieve. So LDL cholesterol of less than 130 and a non-HDL cholesterol of less than 140. So what do guidelines say? So our Indian Society of Nephrology, in Society of Pediatric Nephrology guidelines say that there is a limited evidence to suggest to use anti-lipid lowering drugs. So one would rely on, mode of lifestyle modification, reduction in weight, avoiding the junk food. But despite that, if there is a persistent of hyperlipidemia, one can consider using atorvastatin of 10 to 20 milligram per day. So, so my take-home message from this presentation that complications. So, and our clinical practice is pretty much clear that complications are encountered in patients who have poor compliance to therapy. So either they have not started relapse therapy on time, or they have been on steroid sparing agent which they have stopped and they have not come for follow-up. So these are the patients who develop serious complication. Infection, especially like varicella, can be life-threatening in these patients. Patients should be counseled for, drug holidays, that they should withhold ACE inhibition, diuretics when there is a fluid loss. So thank you. With that, I'll end my talk.
Thank you, Dr. Meena, for your excellent presentation. There are few questions waiting for you. Number one, sir, duration of stage dose steroid therapy.
So there is as such no fixed duration. So, as long as stress is persisting, one would continue the stress dose steroid therapy. So there is no fixed duration that you need to give it for 5 days or you need to give it like 10 days. So as long as, so just take an example of peritonitis of patients, clinically improving at end of 1 week, we would, switch over to relapse therapy regime. So there is no fixed duration.
The other question, the nephrotic syndrome patients on steroid develop varicella. So stop steroid or steroid plus acyclovir, which is the choice?
So patients who develop varicella infection on full dose steroid, one would need to switch over to stress dose steroid. The recommended is, ideally that one would need to give them varicella IVIG, but that's usually is not available in the market. So one can rely on giving IVIG, or so overall, the post varicella treatment is, acyclovir therapy. One would start immediately intravenous acyclovir therapy.
So would you stop steroid?
No, one would switch over to stress dose steroid, not stop it.
Okay. The other question by Dr. Urpita Khemka. In nephrotic syndrome, urine output is already reduced. How reliably can we use urine output criteria for AKI?
So that's, a tricky situation. That's why I, mentioned that one So ideally speaking, when you are defining acute kidney injury, both criteria should be used, creatinine as well as urine output, because that's the most sensitive and specific. But in nephrotic state, just relying on urine output can be a tricky situation because of there might be the adaptive functional drop in the GFR because of hypovolemia. So it's not which was previously used to known as pre-renal AKI. So one cannot rely alone on urine output for defining AKI. One need to monitor serum creatinine as well.
Last question. When to shift from aspirin to warfarin?
Aspirin to warfarin. So we don't use aspirin for management of venous thrombosis. The treatment of choice is either you use unfractionated heparin initially or low molecular weight heparin. One can switch to warfarin maybe after 2 to 3 weeks.
Okay, thank you so much.
He meant that he will changing to change from low heparin to warfarin. I think it was what Dr. Meena already answered. I think one more take-home message is that Dr. Meena possibly didn't highlight. I think it's very important for all of us to remember. The most important take-home message is to follow the guidelines and manage our patient judiciously to ensure that not to use diuretics alone to control edema, particularly in the area, and insurance promptly, make sure the patients are getting adequate immunization, and please to follow the guidelines which have been recently published, and it has also been compiled a very nice published in India as well, which is a very nice guideline for all of us to actually go through and follow it on.
I think Paharida has lost the connection.
So the voice is breaking, I think. So we can continue, sir.
So we'll continue with another session, that is the problem with vaccination in Ankit, and it will be delivered by Dr. Susmita Banerjee. Dr. Susmita Banerjee is the consultant, Department of Pediatrics, CMRI, and she is the honorary consultant, Department of Pediatric Nephrology, ICH Kolkata. She was the member, Senior Advisory Council in Indian Society of Pediatric Nephrology, and associate editor of Pediatric Nephrology Journal, that is the publication of the IPNA. She was the president of West Bengal Academy of Pediatrics, WAP, in 2022, and she was the Central EP member in 2028. She was the pioneer awardee of the East Zone in 2027. So this is very popular, the pediatric nephrologist. Over to you, Susmita.
My slides can be seen, right?
Yeah.
Okay. Thank you very much, Dr. Shopan Rai and Dr. Amitabh Pahari, for chairing this session. And a big thank you to Shumantru and the whole WBAP team for organizing this seminar and for inviting me to participate. So I start with this topic, vaccinations and nephrotic syndrome. And I think you all will agree that of all the pediatric nephrology conditions, nephrotic syndrome is the most common that we all encounter, both pediatricians and pediatric nephrologists. And the numbers are fairly large. And so all these children with nephrotic syndrome, we need to consider what is happening to the immunizations. And therefore, this is a really important topic to talk about at each of these seminars on steroid-sensitive nephrotic syndrome. So what do we know about Ankit so far? We know he has steroid-sensitive nephrotic syndrome, but he has had 5 to 6 relapses in 1 year. So he's got a difficult nephrotic syndrome. He's also had a complicated relapse with possible peritonitis. And because of his frequent relapses and steroid-dependent condition, he has now been put on a steroid-sparing agent, which is MMF or mycophenolate mofetil. Because all this was happening during the sixth year of his life, he has missed out on his booster immunizations, which are usually given in the fifth year. So the questions put to us is, so much is happening in this child's life. Should we bother about vaccinations, or should we try to stabilize him just focusing on his disease? The second question is, if we decide that yes, it is worthwhile looking at vaccinations as well, then is it possible to catch up while he's being treated for nephrotic syndrome? And this question is really important because we find a lot of patients, the commonest age of nephrotic syndrome presentation is between about 2 to 4 years. So they probably would have got their initial immunizations, but since they started having nephrotic syndrome and started on treatment, the majority of them will not have had any vaccinations at all. And the parents are often under the misconception that it is not possible to catch up. So this is an important issue to address. And the third question is, why do we want to target? So one of the questions given to me was, should we immunize his 3-year-old sister as well? So the question is, why do we want to target his 3-year-old sister? So I would imagine that Ankit by now looks a little bit like this, very Cushingoid, and very prone to a lot of complications that are associated with steroid-dependent nephrotic syndrome. So a little bit about vaccinations in children in general. I think we all are aware that vaccinations represent the most important medical innovation in the last 200 years. And this innovation has allowed many conditions, many diseases that used to cause a lot of morbidity and mortality, such as diphtheria, measles, rubella, which used to cause perinatal issues, of course, smallpox. So vaccines have really played a major role in preventing disease in our children. So every country has its own policy for vaccination, and the aim for every country is to fully immunize all children with the vaccinations that have been decided on from country to country. So that is the aim for all children. So the next question is that if we want to protect all children from vaccine preventable disease, should nephrotic syndrome children be any different? So let's look at nephrotic syndrome, and what Dr. Jitendra has already very nicely shown is that nephrotic syndrome is actually increased with an increased infection risk compared to other children, compared to healthy children. And in fact, a large number of hospitalizations and a large number of nephrotic deaths are associated with infection. The reasons have also been discussed in the previous talk. So the nephrotic state itself with edema and ascites predisposes these children to infection. There is loss in the urine of many anti-infective substances like immunoglobulins and complement factors. And there is also documented T and B lymphocyte dysfunction in this condition. In association with these issues, we treat these children with immunosuppressive treatment. And you can see that drugs like steroids, cyclophosphamide, MMF, the CNIs, which include cyclosporin and tacrolimus and rituximab. So these are all the steroid-sparing agents, and this is the steroids. All of them, by different modes of action, they cause a immunocompromised state in the child. So the infections that are common in nephrotic syndrome are peritonitis, which you saw in Ankit. Pneumonia is common, the next most common, and then cellulitis. And actually a host of other infections can also occur, starting from meningitis to tuberculosis, etc. The common infective agents that are usually detected are pneumococcus in the majority, 30 to 50% of the time. Next is E. coli, And then skin, soft tissue infections, you can have Staphylococcus and Streptococcus. Haemophilus influenza can cause both pneumonia and skin infections. And you also have a whole host of viral infections that can cause pneumonia. And as we have already heard in the last talk, varicella can cause very disseminated and severe disease in these children. Influenza can not only cause disease, but it can also cause relapse. So a number of viruses can cause, even with mild infections, can cause relapse. So there is a big association between infection and relapse. A relapse with gross proteinuria causing ascites, edema, loss of the anti-infective agents in urine can cause infection. And infection on its part, whether it be viral or bacterial, can cause a relapse. Now you can see that many of these infections are actually vaccine preventable. And so the pneumococcus, Haemophilus influenza, varicella influenza, and tuberculosis, we have vaccines that can protect children against all of this. But then, when we know that we have effective vaccines, and when we have seen that nephrotic syndrome is associated with even greater infection risks compared to other children, then why are we missing out on vaccinating those children? So the concerns from the parents and sometimes also the clinician is that often that these children are too sick, there's too many things going on, we are changing around their medications, we are looking at the urine protein. So it is very difficult to also take on something extra like vaccinations. There are also concerns about poor antibody response, particularly when the child is in relapse or an immunosuppression. There are concerns that the live vaccines, which are usually live attenuated vaccines, may lose their attenuation when they are given to the immunosuppressed patients, and there may be disease caused by the vaccines. And the final concern that many people have is that the vaccine itself may cause a relapse. Now, if you would like to look at details of the studies that have been performed in nephrotic syndrome patients receiving different types of vaccines and different types of responses to vaccines, these are two articles that you might look at. And what I have done is I have summarized for time constraints. I have summarized the net message from these studies. And what we understand is, yes, there might be a poor antibody response because the child may be immunosuppressed, or particularly when the child is also in relapse. So we have to aim to try and complete vaccines early. So we have to be very up to date with the vaccines in all children, so as to try and see that all children are vaccinated at least up to the onset of the disease. Fortunately, in steroid-sensitive nephrotic syndrome, it is characterized by remission and relapses. So there will be some periods of time when the child is in remission, and we may have some periods of time when the child is off immunosuppression. And these are the best times to catch up on vaccinations. The studies on live vaccines are somewhat conflicting. There are the concern is that there are studies which have shown disseminated disease when live vaccines like varicella are given to the immunosuppressed. There are a few studies which show that you can give live vaccines when patients are on very low doses of immunosuppressants. However, you should be able to demonstrate that they are immunocompetent by doing tests for immunity. Now, these tests for immunocompetence are not always available, particularly in India. So for our scenario, if the child is immunosuppressed, for us, it is best to avoid all live vaccines. The third issue, vaccines, do they cause relapse? Again, there is some conflict in what is understood from the different studies. However, the risk is small, does not occur in large numbers. And the few studies that did show that some of the vaccines like meningococcus, like hepatitis B, influenza may cause relapse, were later negated by larger population-based studies. So again, this is not thought to be a major issue, and we should not worry about the vaccine causing a relapse when we are deciding whether to vaccinate a child or not. Now, looking at our evidence-based guidelines, we have two very recent guidelines from the Indian Society of Pediatric Nephrology as well as the International Pediatric Nephrology Association. And what these guidelines say is that inactivated vaccines, they are safe at any time. So we can really give them at any time. So we should try to maintain the normal immunization schedule of the country. And if by chance, as in the case of Omkit, it has been missed, we should try to update the normal schedule as soon as possible. However, inactivated vaccines, even though they are safe, they may not produce an adequate immune response if the child is immunosuppressed. And also the immunity may not persist for very long. And to try and counteract these issues, we should try and administer these vaccines when either the child is off steroids or on minimum doses. Now, taking into account that some children with steroid-dependent nephrotic syndrome may be on continuous low-dose alternative steroids or other immunosuppression, and in which case we should wait till they are on the minimum amount of steroids or immunosuppression possible. If we have to give the vaccine when the child is on an immunosuppressive, then we should theoretically check antibody titers, and this is possible for vaccines like hepatitis B, like varicella, where antibody titers are easily available. And if the antibody titers are insufficient, we can give extra booster doses or larger doses. Now, many of our really difficult nephrotic syndromes are receiving rituximab, which is a B cell depleter. So if we give rituximab until the B cells are depleted again, vaccines will not be effective, will not produce an immunological response. So we should wait for at least 6 months after rituximab to give any vaccine at all. And we should try to vaccinate update vaccines as much as possible before giving the rituximab. Next, coming to live vaccines, what do the guidelines say? So as I discussed previously, we would like to avoid in our country live vaccines in the immunosuppressed. And the definition of immunosuppressed is if they are receiving steroids 2 milligram per kg per day or 20 milligram per day or 20 milligram alternate day for 14 days or more, or if they are on other immunosuppressants. If patients are immunosuppressed by these definitions, then we should only give live vaccines after 1 month of stopping the drugs. In the case of cyclophosphamide, we should wait for 3 months after stopping the drug. For rituximab, we should wait until there's B cell recovery documented. And the IPNA guideline says we may consider given earlier if the immune status is adequate. But again, as I have mentioned, this is difficult to measure in our country. Further details and specific guidelines depending on the dose the child is currently receiving are given in the ISPN guidelines in this table, which you can have a look at. So looking at the vaccines that are available to us, fortunately, many of the vaccines are inactivated, and we can give them according to the national recommendations or update them as early as possible when the child is on minimal immunosuppression. Live attenuated vaccines we would like to avoid, and we are fortunate that many of these vaccines actually have inactivated alternatives as well, including polio nowadays. However, MMR, varicella, BCG, these are 3 vaccines that we cannot give in the immunosuppressed. Now, in nephrotic syndrome, we should give special focus to the vaccines that prevent the infections that are common in this condition. So we have seen that pneumococcus is the commonest infection that occurs. And the guidelines, both the IPNA and ISPN guidelines, give detailed recommendations on how to catch up if the child is incompletely immunized, or what to add on if the child is completely immunized. So if the child is below 6 years completely immunized, we should give 1 dose of the conjugate vaccine, followed 8 weeks later by 1 dose of the polysaccharide vaccine. If the child is over 6 years, then just 1 dose of the polysaccharide vaccine. And then further doses and regimes are mentioned for those who are not completely immunized previously for pneumococcus. Now, interestingly, the studies show that the vaccination against pneumococcus is effective even in relapse and when the child is on steroids. So possibly on a patient like Onkit, is one of the first vaccinations that we can start him on if he has not received them before. Second, varicella, again, it's a live vaccine, so we cannot give it in the immunosuppressed, but we should take the opportunity when the child is off steroids, off immunosuppression, to try and give the varicella vaccine. And 2 doses given even after the onset of nephrotic syndrome, but when the child is in remission, provides very good immunity that lasts for more than 2 years. Influenza vaccine, as I have mentioned, influenza can be related to relapse, and so an annual influenza vaccine is recommended in all the children. And it has been shown in studies that pre and post influenza, there is a significant drop in relapse rate. So this is definitely worthwhile giving. And hepatitis B, we would like to immunize all children completely for hepatitis B. And interesting thing about hepatitis B is that it is much more effective if given before nephrotic syndrome onset. And the studies show that if you give it after nephrotic syndrome onset, even if you give double doses, the effectivity is less than if it was given during the primary immunization before onset of the nephrotic syndrome. So these are 4 vaccines we need to concentrate on. It's not much point talking about COVID-19 vaccine now because they are not available at the current moment. But during the COVID pandemic, we were advised to administer COVID-19 vaccine as per national guideline without any restrictions to all patients. So now we come back to Ankit. We are told that he received the routine vaccinations up to the 5th year. So it is not enough to be just told this or just take this in history. We have to really look at the vaccine chart and find out what exactly has been given and whether all these very important vaccines like pneumococcus, hemophilus, influenza, etc., whether they have all been given at the right times. Because if they have not been given, we need to update these as well. He has missed his boosters at 5 to 6 years, so this we need to catch up on. And we would also like to give him the optional vaccines which are recommended in nephrotic syndrome patients. That is the polysaccharide vaccine for pneumococcus, influenza vaccine yearly, varicella vaccine when he is off immunosuppressive therapy. So varicella is not something we can give now, but we should seek an opportunity to give it in future. Meningococcus vaccine if possible. Now I'm just going to go through the IFP vaccination schedule because this actually contains many of the optional vaccines as well at the correct times. If we look at 4 to 6 years, this is the age that Ankit is now. The IFP schedule advises the IPV and DPT booster at this time. So if the patient can afford it, this is something that would be really useful to give to Ankit. And again, as I have been mentioning, we should try, he is on MMF, that is not going to change, but we should try and time these when he's on the least possible dose of steroids or off steroids would be even better. The next vaccine advised by IAP at 5 years is the MMR vaccine, but MMR we cannot give because it's a live vaccine. So now looking at the optional vaccines, but that the ones that we would like to give, influenza we can give. It's an inactivated vaccine. We can give it at any time. We cannot give varicella, but we would look for an opportunity to give it in future. We need to go through his PCV history, how many vaccinations he's received for pneumococcus. If he has received the initial immunization schedule, then we can give him a booster of PCV, and 8 weeks later, we can give him a 23-valent polysaccharide vaccine. And we also need to, as I said before, make sure he has received the Hib vaccine and the hepatitis B vaccine. Now coming to the sister, It's not just the sister, but also all close contacts. So parents, other relatives, if they're going to daycare centers, then those children should also ideally be addressed. So, of course, they can receive all routine vaccinations. However, no OPV because this can be transmitted through the stool and cause vaccine-related disease. We would like to take the opportunity to vaccinate the close contacts with the live vaccines because these are vaccines that we are not able to give to the index patient because these conditions are transmitted through close contact. So if we can protect close contacts from getting this, then the index patient is also protected. And close contacts should also receive influenza. So coming to the conclusions, and I think this is really the most important slide. These patients, especially the difficult nephrotic syndrome patients, they are going round and round between the primary pediatrician, the pediatric nephrologist, the health clinic where immunizations are given, sometimes the hospitals, and it becomes confusing both to the patient and to the clinicians because we always think somebody else is looking after the routine things like the vaccination. So who is responsible for vaccinating these children? So I think we all need to take responsibility. Whoever is seeing these patients when they are stable, not when they are having some kind of a dramatic episode, but when they are stable, we need to, each time we see them, we need to look at their vaccination chart, go through the chart, see if we need to catch up on vaccinations, see if we need to give any boosters. And the issues we need to remember is that inactivated vaccines can be given at any time when the child is stable and on minimal immunosuppression. Live vaccines we avoid in the immunosuppressed. However, we look for opportunities to give it in the future when the child is off immunosuppression. And we need to vaccinate the siblings and the close family appropriately. Thank you. If there are any questions, I will stop sharing and take any questions.
There are a lot of questions waiting for you. Number one, newly diagnosed nephrotic syndrome, not received varicella vaccine, no history of chickenpox. Should we give one dose of varicella vaccine and then start the steroid? Or just explain the risk of the varicella and the treatment of exposure, if any, to complete vaccination later?
So, no, we cannot give the vaccination because we're going to start steroids soon. We cannot delay the start of the steroids. So, I would treat the nephrotic syndrome adequately and then try to complete vaccinations. So, 6 + 6 weeks in the first episode, which would mean that after a month, I would go for live vaccinations.
So now the other question, newly diagnosed nephrotic syndrome, this is the same question.
This is the same, yes.
This is the same question. They have given twice anyway.
Yes.
So please advise immunization of the whole therapy while on therapy with ribamizole, MMF, and the CNI.
Yes, so I mentioned this in one of the slides.
This is Amitabh.
Sorry, I could.
The voice is breaking, sir.
Possibly the connection has been lost. No, Amitabh is there. Amitabh, you can switch off your video so that your voice can come clearly.
Sir, please unmute, sir. Sorry, sir.
Yeah. I think my net connection is really to hear me. I have put in the voice box. Can you please answer that question, Sushmita?
Okay,
It's very important for all of us.
Sure. So, if the child is on immunosuppressions like ribamizole, MMF, CNI, then we should wait for at least a month after stopping these medications before giving live vaccination. But inactive vaccines can be given, particularly pneumococcus, influenza, these and the routine inactivated vaccines according to the normal schedule. These should be given we would like to time it when the steroid dose is minimum or when they're off steroids, but they're safe. They may not produce an adequate immunization response, so we might need to give bigger doses or booster doses. But inactivated vaccines can be given. Live vaccines, we should wait for a month after stopping.
The other question, can steroid immunosuppressive drugs affect the titer of protection level of the vaccine whose schedule are already completed?
Yes, theoretically they can. And the maximum effect, I think, is seen in patients who have had rituximab or in patients who are having very strong immunosuppression, double, triple immunosuppression after renal transplant. So if there is a particular risk to a given patient, ideally we should check the titers and revaccinate at the appropriate time. So it is possible. But again, I will repeat that the primary immunization before onset of nephrotic syndrome usually gives better immunity than if we try to update vaccines after the onset of nephrotic syndrome. So the message is really to all pediatricians to try and convince all patients to give immunizations on time.
So there is one question: the patient develops varicella during steroid, whether we should withhold the steroid and treat varicella and or treat simultaneously. This question has been answered by Dr.
Yes,
Already answered.
Already answered.
I can add one issue about varicella, that is, what do you do after exposure? Treatment is with acyclovir, of course, and stress dose steroids, as Dr. Jitendra already said. What do you do if a child on steroids is exposed to nephrotic syndrome? So there is a guideline that because we do not have varicella zoster immune globulin available in our country, we can give acyclovir between 6 to 10 days of exposure as a preventive. But if the child is not on steroids, is not immunosuppressed, then we can give one single dose of the varicella vaccine.
When should you check for the antibody titers after the primary vaccination and booster? What is the general principle?
The most of the studies regarding this is with hepatitis B, where the guideline is that you check 1 month after completing the whole schedule, and then if you have not reached the titer, that is 10, if you have not reached that titer, then you revaccinate and give boosters. So all vaccines will take a month to have maximum effect. So when we want to check for maximum seroconversion, it is usually at a month.
Dr.
think
Rai, can I ask a question?
Oh, sure. Please.
Shmita Di, one genuine problem. A child of 7 years, the first episode of nephrotic syndrome came from a rural area who has not received before the penta vaccine, that is Haemophilus influenzae containing vaccine. So we know that there is a chance of capsulated bacterial infection in nephrotic syndrome. So in that case, how will get her vaccinated against Haemophilus B, because Haemophilus influenzae type B, because it is not available as a single dose, a single Haemophilus influenzae. So in that case, what to do?
I think maybe the pediatricians, Shubhashish, you yourself would be able to give me a better answer.
Can I answer?
Can you give Yeah, Dr. Pahari.
I think if the child is more than 5 years of age, chances of getting Haemophilus influenzae B infection is going to be very, very, very low. So I won't be even looking for separate hip vaccine, Dr. Bhattacharya.
But Amitabh, in nephrotic syndrome, because of loss of opson in the capsulated bacteria, all infection capsulated bacteria due to capsulated bacteria is high. So in that case, should we not go for Haemophilus influenzae?
Most of the children by the age they reach 5, they have got Haemophilus influenzae B natural infection titer already there. So if they have not been vaccinated earlier, in most of the studies that has been done in patients across nephrotic syndrome, we hardly see Haemophilus influenzae B giving rise to invasive infection.
Okay.
And
But
normally
also-
For
don't
the
give
normal children, but I don't know about the nephrotic syndrome. They are that kind of immunities. They are still there or not.
One thing, if I can
I'm
add,
talking here about nephrotic children only.
if I can just add, there is a
Carry on.
lot of issues with availability always where vaccines are concerned. HIB is not available on its own. I think IPV also is not available on its own, right?
IPV is available.
IPV single dose is available on its own.
It was available it was available, but at present I can't
was,
say.
yeah,
Now
I
it is
was
not
just,
available.
No.
yes,
Actually,
I was
it
just,
is
But
available,
IPV
but
is not available.
so the issues, we always know the theory, what we should do, but the practicalities are always a little bit different. And I think, from the point of view of IP, WBAP, these are the things that we need to sort of talk to the manufacturers about, at
Right.
least to make some vials available for high-risk children.
Right.
Only option would be to give a
Sorry, Amita, once
vaccine like
again.
Pentaxil. Yeah, the only option I think here would be to give a Pentaxim kind of a vaccine, like which has a acellular DPT.
It does well.
So probably
hit
would not
along
cause any harm, but would booster everything, booster all the other
Then-
vaccines,
Absolutely.
as well as
Absolutely.
provide him.
Yeah.
But the thing is, then how many doses do you give? No?
Amita, your voice is breaking.
Yeah, I think, this is a wonderful session. I must thank all the speakers and my co-chair, Professor Sapun Rai, for conducting these sessions so well. Unfortunately, my voice was often breaking because I'm actually, taking it from a remote area in my village. Many thanks to the organizers and all the faculty and Professor Rai. We are closing this aspect of the session today. Please wait for the quiz session to start. Thanks a lot to everyone.
Thank you. Thank you.
I will request both of the chairpersons to kindly stay for the sessions because the next session will be most exciting. So we are going to start our quiz session now. The link for the quiz are already being shared in the delegates WhatsApp group and also in the chat box. We will again share it again. So for regarding our quiz session, so today we'll be having our quiz session. Our quiz master will be Dr. Rohit Bhaumik. Rohit sir is from our AIMS Kalyani. He is the assistant professor and he's done his post-graduation from PGI Chandigarh and his postdoctorate from JIPMER. And he's currently the PICU in charge. And he's already known in Pan Bengal and also Pan India for his this quiz conducting the super quiz. So and the judge will be our the mentor of the whole program, Mihish sir, and along with our both of the two chairpersons will be assisting Mihish sir for judging the whole session. So next platform will be to Dr. Rohit. So Dr. Rohit and Dr. Mihish sir, you can please talk it. Over to Dr. Rohit, please.
Rohit, go ahead.
Good evening all. Thank you for the opportunity for conducting quiz again. So the rules has been shared with all of you. So you can click the link and you can leave this platform also. No need to stay both. So we'll start soon.
So the rules for the quiz were already shared by Dr. Rohit in the WhatsApp group. So
Yeah.
we'll get has gone through it. It's not simple also.
So yeah. Sorry, madam. Yeah, so people are joining slowly. 20 people join. So we'll wait for 1 or 2 minutes.
So if our participants are leaving, kindly redo join after once the quiz session is over. Please rejoin once the quiz session is over for the rest of the discussion of the answers and of the declaration of the results by our judges.
So many people joined.
So if anyone have any queries regarding not able to join, please mention in the chat box.
Shall we start, sir?
Just 1 minute, Rohit. I think.
Okay.
So now 40 delegates has joined, no, in the Mentimeter.
Yeah, it is showing,
So
sir. 40.
Kartik has mentioned he is not able to join. The link is given. You can go out from the Zoom. You can disconnect the Zoom, leave the meeting, and join in the Mentimeter link that has been shared. If you have a good internet connection, you will be able to join.
Sir, just let me know when to start, sir, because now I am
Yeah,
only
so
able to see the.
yes, yes, you can start now, Rohit. Already 48 delegates, 49. Yes, you can start now.
Okay. So the first question is coming to your mobile. Which is considered as frequent relapse nephrotic syndrome or SDNS as per ISBN 2021 guideline. So question number 2, leukocytopenia is associated with therapy of the following drugs. Which drug? Levamisole, prednisolone, rituximab, cyclosporine. So majority answer levamisole. Third question. A 5-year-old boy with SDNS with steroid threshold of 0.8 mg per kg now develops steroid toxicity. Cushingoid without other feature of steroid toxicity. The second agent of choice. So majority answer levamisole. Question number 4. Which is not a part of monitoring for adverse event during levamisole therapy. CBC, SGPT, ANCA, creatinine. So majority answer creatinine correctly. Question 5. Inactivated vaccines in nephrotic syndrome, which of the following is true? So PPSP 23 is recommended only in patients over 23, over 2 years. Question number 6. True regarding rituximab. It's an anti-CD19 agent, suitable agent if a STNS child develop diabetes. Better user profile in less than 5 years of age group, as child goes off steroid fast. Need to monitor CD20. So correct answer is suitable agent if a STNS child develops diabetes. Question number 7. Regarding live vaccine in nephrotic syndrome, which of the following is true? Varicella vaccine plus a cycloped treatment for a nephrotic syndrome child on CNI exposed to varicella. Live vaccine contraindicated whom received rituximab 2 years back. Live vaccine should be given after stopping steroid 1 month and no other treatment. IPV cannot be given to sibling, but OPV can be. Very good. Live vaccines be given after stopping steroid for 1 month and no other child is not on any other. Question number 8. Which of the following reduces absorption of tacrolimus? Iron, calcium, antacid, vitamin C. So majority answer correctly, antacid. Question number 9. Regarding vaccination in children with kidney disease, which of the following is true? All vaccines should be given exactly as the national immunization schedule. If vaccinations are up to date, no further attention is required. Some extra vaccine not available in national immunization schedule are recommended in syndrome patient. All vaccines are contraindicated. Immunosuppression. Excellent. Some extra vaccines can be given. Question number 10. Disappearance of proteinuria by which week? First week, second week, third week, fourth week. In majority of patients. So correct, it is second week. Question number 11. Again, on vaccination. Yes, majority again correct. All of the following are required to make the diagnosis of nephrotic syndrome except so almost everyone correct. So serum cholesterol is not there in current guideline. All of the following investigations are essential at the onset except so perfect. Is not required. A child with recent onset nephrotic syndrome, so positive tuberculin skin test, which is the next step, best step. Which of the following is false? So correct. 24 hours urinary excretion is not mandatory for everyone. Question number 16. All involved in the development of edema in nephrotic syndrome except RAS activation, excessive salt intake, increased renal absorption of sodium, decreased release of vasopressin, which of all is not there. So decreased release of vasopressin. Question number 17. True regarding cyclophosphamide. So better avoid in more than 13 years old boy if it's question number 18. So maybe on patient is on shock, receive bolus, next best. %. Albumin is the correct answer. Question number 19. True regarding calcineurin inhibitors. So excellent. Tough table requirement is more in tacrolimus. Last question. It's a big question. So it's over. Me, sir?
Yeah, great. So it is not the correct answer, but also the time is important. So it's going to give the yes. So Dr. Sayanton Day has the highest point. So 10,188. So Dr. Sayanton Day has secured the highest point. Next, Rohit.
Dr. Jigisa. And
Okay.
third is Dr. Karthik.
Next. Okay, so Dr. Sayanton Day secured the highest point. Next is Dr. Jigisha, and next is Dr. Karthik. So very close marking. So it is not only the correct answer, it is the time, how fast you have answered. So that is also been taken care of in this app. So congratulations, Dr. Sayanton Day, Dr. Jigisha, and Dr. Karthik. So Rohit, you can add them in the panelist link if they can open their videos and
Okay, sir.
say a few words.
Rohit Mukherjee, can you do that?
Yeah, sure.
Dr. Rohit Bhumi, can you read out the names once more for Dr. Rohit Bhumi?
Dr. Shayantande, Dr. Jigisa, Dr. Karthik.
Oh, that's fine. So very nicely conducted quiz, sir. Overall, a
Yes,
perfect.
very nicely. And it is the beauty of this
Perfect.
app is that
Yes, sir.
yeah, it is all automated. You don't have to do anything because if you feed the right questions and the right answer and time, then it will be all automatic.
And also
Yes,
the
sir.
man behind the show is also a real gem. That is also a add-on beauty. So are they in the panelist, Mr. Rohit Mukherjee? Dr. Sayantan,
Dr. Shayantan is in the panelist. Dr. Jigisha Das and Dr. Karthik is joining shortly.
okay, sir.
Okay, Dr. Shayantan has joined. So, Dr. Shayantan, can you unmute or you can open your video? And also, Dr. Jigisha.
Yes, sir.
From which
Yes, sir, I have unmuted, sir.
Dr. Shayantan, can you introduce yourself? You had from your institution. What are you doing?
Sir, I am first year PGT from Medical College, Kolkata.
Arey wow. Yeah.
Oh, excellent.
Congratulations.
Our Shayantan.
It's our
Congratulations.
Thank you, sir.
And Dr. Jigisha?
Sir, myself, senior resident at SCB Medical College, Cuttack.
Okay,
Okay, excellent. So,
Sir, I
SCB
was
Medical College.
PGT at Dr. B.C. Roy, Kolkata. DNB PGT.
Okay,
I
great.
completed, sir.
nice one.
Great, excellent.
Congrats.
So, SCB is also his own
Thank you, sir.
college, no?
Yes, sir. And Dr. Subodh Pradhan is the PGT nephrologist there who are training those
Yeah.
JRs and SRs on nephrology. Congrats.
Okay, Dr. Karthik.
Sir, I'm first year nephrology PG from Tamil Nadu, sir.
From which college?
Which
Tirunelveli
institute?
Medical College.
Okay, okay. Congrats. Congrats for the nice.
Congratulations. Okay, so I will request both Sayantan, Dr. Jigisha and Dr. Karthik to give your details in WhatsApp group to Dr. Rohit Bhomik or you can give to Dr. Sumanta also your bank account details because you have won the quiz, so you are liable to get the cash prize. So as we have declared the first prize 3,000, second prize 2,000 and third prize 1,000, we will transfer that to your account. Okay, please make sure and send it to Dr. Sumanta Raut or Dr. Rohit, Mr. Rohit Mukherjee. Okay.
In the same WhatsApp group, you can do that. We have a delegates WhatsApp group.
You can send in the same WhatsApp group in the delegate.
All three are the participants of the WhatsApp group, na? Dr. Sayantan, Dr. Jigisha, and Dr. Karthik.
No, sir, I'm
Yes,
not in
sir.
the group.
Okay.
Yes,
do
sir,
you
I
have-
am there.
So I'm just putting my phone number there. So you can please DM me. Okay.
Okay, sir.
Will you continue, please?
Okay, thank you, Rohit, Dr. Rohit Bhomik, for excellent quiz. As always,
Thank
this
you,
is the
sir.
sixth time, no? You are conducting the quiz and
We need to discuss the answers very briefly on within 5 minutes or 6 minutes for the other participants.
yeah. So within very briefly, you can just go through the answers.
Only briefly. Only just briefly.
Okay. So
Already
we have the all separate PPTs there for questions.
Sir, I can share it is like that only.
Yeah, no problem.
Uh,
On that view only, we can jointly.
yeah. You can. I'll show Sumanta that is visible.
It's visible. Which is the first question?
So इसमें है ना?
FRNS
Yeah.
as per ISPN guideline. So questions from day 1 of talk, and it was covered by the definition part by Dr. Devlina and also by Dr. Dibedu. So it is the recent changes only. There we need at least 2 relapses in first 6 months, otherwise 4 relapses in a 12 months. That is the definition. So the correct none of the things for the correct answer. 4 relapses in 12 months, first option gone. 2 relapses in only first 6 months, not any 6 months, second option gone. And first relapse and onset is not a policy. Always 2 relapses while on steroid is considered as FRNS or STNS, not the onset at the present. So none of the option is correct. Second question.
Sumanta, hello.
Yes, please.
Participants joined back, na? They are there. Because I can't see right now how many participants are there because they went to WhatsApp group.
47 are there,
But-
including
Oh, fine.
the daily faculty.
33 has joined.
Fine. Okay. Second question.
Just a bit.
Sumantada.
Leukocytopenia
Leukocytopenia.
therapy. Okay, this is also discussion during the second agent side effects. This is also from yesterday's class. And we know steroid causes leukocytosis and rest of the drugs, levamisole, MMF, and also endoxan that causes leukocytopenia. So levamisole is the correct answer. Next.
This one.
So for 5 years old STNS,
Five.
threshold of 0.8. This is a low threshold steroid because probably 5 years old boy may be of 25 kilo and high threshold is more than 0.1 milligram per kg. So this is low threshold steroid dependent and only Cousignard, but no other mild Cousignard and no toxicity. So we'll choose a low, milder drug, any steroid sparing drug, and levamisole is the first option of steroid sparing drug. So if the threshold is high or the child will have a more complicated toxicity like huge Cousignard, what Dr. Jitendra has just written in the chat box, then our cyclosporin or other higher option will come into play. So the answer will be levamisole. Correct answer by 31 candidates.
Yeah, majority.
Next question, please. Which is not a part of adverse event monitoring in levamisole? That was also yesterday's question. So we need to look for cytopenia. So that's why CBC, transaminitis, so SGPT, and the one of the newer side effects of levamisole, that is ankavasculitis. Not a new side effect, but it is known recently for last 6-7 years. So this is ankavasculitis. So the answer is routine creatinine. It is required for monitoring of nephrotic per se, but not directly for levamisole, as levamisole is not nephrotoxic.
So majority corrected.
Majority is correct. Regarding activated vaccine, now can the rest of the speakers can take it? So Sushmita ma'am, can we? Is Sushmita ma'am is there? Or Subhankar?
I am here, but you go ahead. You're doing a very great job and you're going fast. Go ahead.
So regarding inactivated vaccine is nephrotic syndrome, which of the following is true? So for PPSP, we know that for inactivated vaccines, once the pneumococcal vaccinations cannot be given to space on steroid. This is wrong because if your steroid dose is less than 0.5 milligram per kg alternate day, even if on any other second agents, we can give pneumococcal vaccines as this is a kill vaccine. So first option is wrong. Third option, influenza vaccine can cause relapse. That is true, but for that reason, we don't avoid influenza vaccine at all because more often a flu can trigger a more severe relapse. So despite the fact that influenza might cause some amount of relapse in some patients, we still go ahead and give the vaccines to the child who are appropriate for the candidates. So this is third option is wrong. Fourth option, 3 doses of FB to nephrotic syndrome confers lifelong immunity. No, it's not right because immunosuppressed patient, as for other patient also, just also nephrotic, they need repeated monitoring of their antibody titer. And whenever their titers goes below 10, we need to revaccinate them. Every 5 yearly, better to check the titer and revaccinate if the titer is low. So the option B is correct. PPSP to be given when the child steroid dose is less than 0.5 alternate day, maybe while on any second agent, but more than 2 years of age. So next question. True regarding rituximab, it is an anti-CD19 agent. Wrong, it is CD20 agent. Suitable agent in STNS child developed diabetes. Yeah, it's correct because on rituximab, we can make the steroid off within a weeks. Better use if the child is less than 5 years. No, it is wrong because yesterday it was discussed. Lesser the age, more common is the immunoglobulin, lower immunoglobulin profile. So need to monitor CD20. No, it's also discussed last day. We need to, it is an anti-CD20 molecule, but we need to monitor CD19 because of internalization of the receptors. So option B is correct. Regarding live vaccines in nephrotic syndrome, which the following is true? Varicella vaccinations, treatment for a nephrotic child on CNI. Sorry, I can't see properly. Yeah, right.
Varicella vax.
Yeah, I can see it. Vaccinations plus acyclovir, treatment for a nephrotic child on CNI exposed to varicella. So if the child is already on CNI, we can't give vaccines. Only acyclovir if there is a symptoms properly. So first option is wrong. Live vaccines contraindicated to whom received rituximab 2 years back. Usually, as madam told, it was just a 6 months of duration post rituximab when the live vaccine is contraindicated. So option 2 is wrong. Option 4, IPV cannot be given to siblings of OPV, to siblings, but OPV can be given. No, just the reverse. We can't give oral vaccines to the siblings because they will pass the vaccines through the stool and they infect the diseased person, the nephrotic child. So only IPV can be given. So option 4 is also wrong. So option 3 is correct. Live vaccines can be given 1 year post omission of steroid. And majority has answered correctly. Next question. Which of the following reduces absorption of tacrolimus? Obviously, most of the drugs and food and diets, everything reduces tacrolimus other than your grapefruit juice. But among them, among the 4 options, antacid does it most. So most people have done the correct answer. So regarding vaccination in children with kidney disease, which of the following is true? So all vaccines should be given exactly as per National Immunization Schedule. Yeah, right. But if the child is on a high dose steroid of more than 0.5 alternate day, we can't give at that time. So option 1 is not right. Number 2, if vaccinations are up to date, no further interventions required. No regular monitoring of booster, as ma'am told, regular monitoring of booster dosing or catch up is required. Number 4th option, so number 2 is wrong. Number 4th option is all vaccines are contraindicated in immunosuppressed patients. No, it's not right, because if the child is on low dose steroid, we can give the kill vaccine at least. So number 4th is wrong. So number 3 is correct, and majority has done is correctly. Most patients in pediatric nephrotic syndrome responds to prednisolone with disappearance of proteinuria by the end of 2nd week. Correct. The median time is approximately around 14 days for first episode. So the answer is mostly correct. And that for that reason, we need to do daily diary, heuristic diary monitoring, what Dr. Dibendu has discussed yesterday. Regarding vaccination in nephrotic syndrome, which is true, NS even in discussed already, even in remission is immunocompromised state, hence no vaccination. No, once in remission and off steroid for 1 month can be vaccinated if all second and all who receive steroid in past 1 year are immunocompromised. Maybe right, but we can give once off steroid for 1 month live vaccine and kill vaccine even on a low dose steroid, as ma'am told. It's a repeat question. And so number 2 is out. Number 3, inactivated vaccines are ineffective in patients with immunosuppression. It is not ineffective, it may be some less effective. So we still go ahead and give inactivated vaccines. So option 3 is also wrong. So option 4 is the correct answer, and majority has answered that. All of the following are required to make the diagnosis of nephrotic syndrome, except, yeah, as per reset guidelines, this cholesterol has been omitted from the ISPN 2021 guideline. Rest of the diagnosis part is correct. That is described by Dr. Devina yesterday. And this is the only question, I think, where 100% correct answer was there, no? For the definition of nephrotic?
Yes, almost.
So all of the following investigations are essential at the onset of nephrotic. Correct. Urine routine examination mandatory. Albumin level essentially mandatory. Tuberculosis test as of from India, it should be done for most of the centers. Ultrasound KUB is not a mandatory thing unless you are suspecting some other structural disorder known for. So correctly answered by majority. Child with recent onset of nephrotic syndrome shows positive tuberculosis skin test. Here actually all have been made cross. I think the options would be, as Dr. Subhankar also discussed last time, and Dr. Chandra was told, might be we are going for a chest X-ray, and majority of them are not right. So none of the options are correct. This may be a yes. So we are
is a nullified.
No, it is not. So which of the following is false? So persistent microscopic hematuria is not seen in minimal change disease. Correct. So is usually not seen. So serum C3 and C4 level are normal in FSGS. Yes, it is right. 24 hours unit protein excision is mandatory for the diagnosis. No, it is not. So this is the correct answer. This is not mandatory at all. Only a dipstick or a routine test or maybe a spot urine test we can do. Any of the above, including 24 hours. Any of the above thing is enough. So 17 is correct answer given by majority. Next questions. All are involved in the development of edema in nephrotic syndrome, as Dr. Subhankar just discussed. Decreased release of vasopressin. No, nephrotic syndrome is a high ADH state which causes free water retention and hyponatremia. That was a doubt in the chat box also. So this is the only exception. This is a high ADH state and not a low ADH state. So 16 is the correct answer. Excessive salt intake. Okay, fine. So true regarding that's fine. That's fine. Carry on. True regarding cyclophos. Not to be stopped if the child develops repeat proteinuria, as it was also discussed yesterday. For any second agent, if the child develops first relapse, we don't need to stop mebamizole, stop MMF, stop tacrolimus if the child is non-infected. The exception is cyclophosphamide and rituximab to be stopped if there is a relapse in between. So we need to stop cyclophos. It's better works for less than 7 years. No, as also discussed yesterday, cyclophosphamide don't work well with less than 7 years child in most of the studies. So if there is a chance, always try in a child who is more than 7 years, but also avoid in a upper age that is more than 13 years boy, better to avoid due to the potential gonotoxicity risk is much more than that boy. So option 9, option 3 is correct and given by the majority. And it is not given on alternate day. Levamisole is given on alternate day. Steroids long term are given on alternate day. MMF, cyclophos, tacrolimus are given on daily dose. Next, so a boy with nephrotic came with anasarca, decrease in output, hypotension, and hypovolemia obviously. So the volume is trying to restore with 1 bolus, partially corrected. Still he is hypovolemic. So we need to give a better volume. And to give this volume, either try a second bolus or maybe giving a albumin, and that too not a low volume albumin, not 20%. It's a high volume, low concentration albumin, that is 5%. So option B is correct. True regarding CNIs. Cyclosporin is more nephrotoxic than tacrolimus. No, they are equal in that segment for nephrotoxicity. Tacrolimus is better than cyclosporin. If FTNS child develop diabetes, no. Tacrolimus is diabetogenic, where cyclosporin is diabetic prevention. In SRNS less than 3 years, tacrolimus is better choice. No, tacrolimus in India is available in capsule form. Less than 3 years, usually it cannot engulf that toto. Cyclosporin is available also in syrup form. So for less than 3 years, cyclosporin is the drug of choice. So all the 3 options are wrong. Trough level answer is correct and given by majority. So skip. 6 years boy with STNS admitted for edema control and abdominal pain. History of 4+ proteinuria for 2 weeks and decrease in output. Sodium 124, potassium 5.2. So how to treat this hyponatremia? Do we need to give 3% saline? Usually no. Even if a low salt albumin, which is available in most of the centers in India, they even contain a sodium content of 130 to 135. So purely a albumin infusion with a low salt content albumin will hike up the sodium. Number 1 cause due to the sodium content itself, and number 2 by increasing the volume, the ADH will get suppressed. The ADH, which is very sky high, now will get suppressed and the sodium will be corrected. So for these 2 reasons and many other reasons also, the sodium will be corrected. No need for 3% saline if the child is not having seizure or other acute symptoms of hyponatremia. Next. So number C is correct and majority has given the correct answer. So
Yes,
all
sir.
wow, thank you. And all so the board is over to you, sir. And our all senior dignitaries from WBP and ISPN also. I think all the dignitaries are there also. So any feedback to be taken from candidates? 3 of the candidates are in the panel. The candidates can write the
I
chat
think the
box.
Sumonto is already 10 past 7. So I think we can end here. So they can give the feedback in the WhatsApp group because they are the group. Yeah. Thank you, Sumantra, again, and thank you, Rohit. And Sumantra has, within a short span of time, and explained it very briefly, all the answers. Now, I again thank the whole team of BSPN and West Bengal Academy of Pediatrics for conducting this session very successfully. And as yesterday's, today's also have very great sessions and very good interactions. And I can see also the Susmita madam, you can give or Subhasis, then Subhasis Bhattacharya sir, give your comments on that, then we'll end here.
Thank you. I think it was a really excellent session and would be very nice to repeat this every year, really. Congratulations to all who participated, organized, the delegates, the faculty. Very well done.
Thank you, madam. Subha sister, are you there? Subha sister was there.
Mr.
Scientific.
Jayati ma'am is also there from BSPN. Can we request Jayati ma'am to?
Yes.
Jayati ma'am, can you please unmute and say a few words from BSPN team? Yeah,
it was a wonderful session. Yeah, really. And I'm so happy that so many people participated in the quiz and they stayed back till the end. I think it's a very good initiative. We should keep this going. And I'm very happy that BSPN could be part of this along with WPAP. And I'm sure, we'll be very, very happy to host similar events in the future. If required, even for a longer time or over a period of about 2 or 3 days through the weekends, and each and different aspects of pediatric nephrology. This time we discussed mainly nephrotic syndrome, but other important aspects which are often very confusing to students and general practitioners, they can also be tackled, and that will be, I think, very useful for everyone. Good learning curve. And congratulations to all the people who won the prizes and who participated.
Kalpana ma'am and Sapal sir.
Thank you.
Sapal sir also there, Kalpana ma'am also there. Me sir?
Yeah. Kalpana ma'am, I cannot see Kalpana ma'am is there. The Professor Sapon Kumar Roy is there. Professor Sapon Kumar, please give your final comments, then we'll conclude.
I must thank Dr. Sumanto Raut and his team with Rohit, DRC, and obviously Dr. Mihir Sarkar for showcasing a beautiful today's Nephro Class session. And I thoroughly enjoyed these last 2 days, today and yesterday. And I must thank all the faculties who have joined, like Dr. Shubhankar and Shubhankar, Dr. Sushmita Banerjee today, Dr. Meena, and yesterday all the faculties they have joined. So WAP is eager to showcase this type of program in futures also. And I will request all the delegates to be present in our next endeavor. And I must thank Rohit Mukherjee, the son of Mr. Somnath Mukherjee, who has done a splendid job. In fact, flawless flow was going throughout the last 2 days. So thank you, Rohit, because I have seen Rohit from very early age. She was very tiny boy at that time. So thank you, Rohit.
Thank you.
Because my association with Somnath is more than almost 2.5 decades.
Yeah.
Thank you, Rohit.
Thank you.
And I must thank all the EB members who have joined here yesterday and today. And I must congratulate them for even the interactions they are doing today. And so hope to meet you soon. Good night, everybody. Stay safe.
Okay, good night.
Good night.
Good night, sir. Good night.
Good night, and